A very good evening, everyone. I hope you all are doing good. You're following your schedules. The panic mode is over. You're just keeping up with the pace. There should be no stress. You are done with your syllabus decent number of times, and the last revisions are going on. Well, and if all is okay, if you can hear me, if you can see me, just give me a thumbs up as an assurance everything is working well. And a little word about before I start. Well, this session, FMG 150, is basically targeted to build in your short memory. We've done so many discussions, we've learned through so many detailed courses. So, this 150, the target FMG, is to build in your short memory. That basically means there will be two sessions that I would be taking. So there will be basically two sessions. So those two sessions, one is today, which will be 1.5 hours each, right? And one is today, which is on 21st, and the other is on 24th. So these two are basically for building your short term memory. By that, I mean I would be playing with your short term memory in a way that whatever we have learned, even if you do not remember, we're going to go a rapid fire MCQs so that if the same questions are repeated, you do not have to waste time on reading it, on trying to solve it. And even if you do not remember the theory, even if you're not able to make up, connect the dots with the as far as theory is concerned, you can attempt the right answer. So, without wasting any time further, hello everyone, a very good evening. So, basically, I would quickly start the session, and my target is covering up to 150 MCQs. Covering up to 150 MCQs, which has all the previous year questions plus the anticipated questions plus all the recalls of NEET PG, which have the high chance of coming back. All right. So this is all going to be in two sessions, 1.5 hours each, which is one today and the other is on Monday. So that you have decent time to just quickly go through them. And this is a rapid fire MCQ. Short-term memory potentiation, absolutely, right? So we've tried to the entire year we've been building up with the theory, with the information. So now it's a smarter way to do things, and as I always say, study smart. All right, so without wasting further, let's begin. So before I start, I would just quickly give you a word about the iconic subscription. For you, I know, I'm sure you're going to go through this one. So this is for you to give to your own juniors. So which is offering you Unacademy Plus. It's giving you notes and a mentoring session and add special offer prices. This is really the reduced one, and you can use the code Bhumika for all the added benefits. And especially, I would like to mention anyone who's taking a 9 months subscription is getting 2 months subscription added, absolutely free, extended up till 11 months. Right? So, again, that is at a special offer price, and you can use the code, which is my name, for any added benefits. All right. So now, without wasting any time further, let's begin with this. So the first question on the screen. So I told you my target is up to 150 MCQs in two sessions. So no major discussions, but all the relevant and quick MCQs, right? So you will get 1 minute per question, and here we start. So we have a male with history of liver disease, developed cataract as shown in the image. Which substance is deposited in cornea? So you have to tell that which substance is deposited in the cornea, and here you should have the answer. Absolutely. So everyone has said A. Very good. So if you can quickly name what you see in image A what is image A and what is image B. I know we have discussed this so many times, but I'm telling you, it is nothing new. These sessions are meant to give you short-term memory and give you the confidence. All right, so tell me, what disease are we dealing with? One, what is the name of picture A? What is the name of picture B? I want these three things in the chat box. You all are absolutely right. So what we are talking about is a disease which is dealing with copper metabolism, and that disease is the Wilson's disease. What are we dealing with? We are dealing with Wilson's disease. And what is the other name of Wilson's disease? We are dealing with Wilson's disease. What is the other name of Wilson's disease? It is also called as hepatolenticular degeneration. It is also called as hepatolenticular degeneration. And what are we dealing? Absolutely. Very good, Rohit Pandey. And what is A? A is KF ring. Very good. So what is A? A is KF ring. Perfect. A is the Kessler Fleischer ring. Very good. Where is the Kessler Fleischer ring? If you see here, there's a brown pigmentation. And what is B? B is the sunflower cataract. And we all know that both of these do not impair vision, and it deals with copper metabolism, right? So these are the takes from this question, and we move on to the next. So S in SAVE strategy stands for. Tell me. S in SAVE strategy stands for. When we talk of SAVE strategy, which disease are we talking of? Tell me. B. Perfect. Everybody says B. Absolutely. So let's see. When I talk of a SAVE strategy, which disease are we talking of? Tell me. Absolutely. So what are we talking of? We are talking of trachoma. You're talking of trachoma. And this SAFE strategy was given by WHO under the GET 2020 program. And what is GET 2020? Can anybody elaborate what is GET 2020? GET 2020 is Global Elimination of trachoma by 2020. All right. So this was a SAFE strategy. So what are other things in SAFE strategy? When we write SAFE strategy, by that, what do we mean? So what is A? Tell me quickly. What is A? What is EFA? You have to tell me now. Okay, so you say S, we all know is surgery. A, you have said is antibiotics. Very good. The drug of choice being azithromycin. What is F and what is E? Absolutely. E is environmental factors. And F is, anybody wants to attempt? What is F? Is facial hygiene. So whenever we talk of SAFE strategy, this is what we are dealing with. It is the facial hygiene. So let's see when we talk of this question. So this, you clear? So SAFE strategy, we're talking of trachoma. SAFE means we go like this. First is the environmental factors which you need to change, facial hygiene, you give antibiotics, and last for the complications, you do surgery, right? So this is trachoma. All right, so moving on to the next question. It says a female presents to the OPD 3 years after cataract surgery and complains of painless progressive diminution of vision. Slit lamp evaluation shows the below image and the foveal contour is maintained on OCT. What is the probable diagnosis? Tell me, is it cystoid macular edema? Is it IOL drop after cataract or retinal detachment? Rishiraj, good evening. We're already through 2 questions. Anyways, you're good to join in. You can see these questions later. So, all right. So, everybody is saying after cataract. What is the other name of after cataract? If I have to write here, what is the other name of after cataract? You're absolutely right. The answer is after cataract. What is the other name of after cataract? So what you see in this image, you can see all this is posterior capsular opacification. So when we talk of after cataract, we talk of PCO, which is famously called as posterior capsular opacification. Right? So this is the most common cause of late diminution of vision post cataract surgery. Also, if in the above question I change a bit and I make it in a manner that the foveal contour was disturbed. If the foveal contour was disturbed, then what would be the answer? And thus no image is given. Then what would be the answer? Tell me, if I present to you a similar question, a female 3 years after cataract surgery with painless progressive diminution of vision, but OCT shows a foveal reflex which is dull with cystoid spaces in the intraretinal cystoid spaces. Yes, Akshat, absolutely right. If the FR is dull, or OCT shows macular edema, then the answer would be cystoid macular edema. So, cystoid macular edema again causes a painless progressive diminution of vision. So, you get the 2 questions. So, if the question talks about the foveal contour being normal and there is a picture like this, so that is PCO, which is the most common cause of a late diminution of vision post cataract surgery. But if the question talks of foveal reflex being dull and the OCT findings of the edema, then the answer would be cystoid macular edema, or which is famously called as the Irwin gas syndrome, or which is also called as Irwin gas syndrome. Okay, is that clear? No doubts? Is that fine? All right. So now you have to tell me, identify what are these. Identify image A. What is the name of these? B and image C. What is all these are related to posterior capsular opacification, or which you call is the secondary cataract, or what you also call as after cataract or after cataract, right? So tell me, what is A, what is B, and what is C? The hint is these all are related to posterior capsular opacification. So anybody who wants to attempt, what is A? Absolutely. B is, you are right, absolutely right. B is the Soimering ring. Very good. So what is A? Good. A is the Elchenig pearls. Very good. And what is C? What is C? You can see an opening here. So basically something which has been done to this to come down to this. Something has been done in image A to come down to image C is. So what do you see here in the center? What is it? So this is basically YAG capsulotomy. This is YAG capsulotomy has been done. All right, that is the treatment for posterior capsular opacification. Is that clear? So all these two are basically the variants of presentation of posterior capsular opacification, which is Elchinic pearls, which is shown here, which are these fish eggs which you can see, or it can be a ring pattern which is called as the Soemmerring's ring. So what you do is you create an opening in the central part, which is called as YAG capsulotomy. All right. Okay. So with that, we move on to the next one. So here the question says, a 34-year-old male working as a welder came with the complaints of pain, redness, and watery eyes. What is the management? So before you go to the management, tell me what is the diagnosis of the image. What is the diagnosis and what do you get to see in this image? All right, I take that. Absolutely, yes. Very good, Dhruv. And Chandni, no, sorry, it is Dhruv who has answered B, foreign body, foreign particles. Absolutely, Sridevi and Dhruv, what you get to see here, I'm sorry for that miscommunication. So, what you get to see here is a foreign body. And what is the correct answer? The correct answer is active intervention with antibiotics. And what is the active intervention? That you have to remove the foreign body. So let's complete this answer. So active intervention is remove the foreign body, followed by antibiotics. You say liberal wash. Liberal wash is no, because where do you do liberal wash? Liberal washing is done in all the chemical injuries. So chemical injuries you will do liberal wash. So that is not the answer. Keratoplasty, absolutely no, does not seem here, and none of the above. So the answer is remove the foreign body, do an active intervention, and give antibiotics. All right. Okay. So let's move on to the next one. What is the position of lacrimal sac? What is the position of lacrimal sac in the orbit? So before we attempt this question, you have to tell me this is 1 and this is 2. Where is the lacrimal sac and this is 3? Is it 1, is it 2, or is it 3? So you have to tell me which out of these options is lacrimal sac. One is the lacrimal gland. Very good. So one you say is the answer is one is the lacrimal gland. Good. So what is 2? One is lacrimal gland. Perfect. What is 2? What is 2? Tell me. I said before you answer the question, you need to tell me what are these structures. What is 2? It is not the duct. 2 is not the duct. So tell me what is 2? Yes, 2 is basically the lacrimal sac. And what is 3? 3 is okay. So there is a valve here which is called as the valve of Hasner. Very good. But this is, yes, 3 is the nasolacrimal duct. And this valve here is called as the valve of Hasner. Perfect. Is that clear? So we have the lacrimal gland, which is present here. So if you know these structures, you identify these structures well, the question cannot be wrong. Maybe they ask lacrimal sac or they might ask anything else. So what you have is lacrimal gland. This is the lacrimal sac. and here it is followed below as the nasolacrimal duct, and here is a valve which is called as valve of Hasner. So now tell me, what is the answer to this question? Yes, the answer is, you're absolutely right. The answer is medial wall, because it has asked what is the sac. So where is the sac? This part in green is the sac which is present on the medial wall, right? So this is the lacrimal sac which normally opens in the inferior meatus, as Chandani has rightly written, right? So that is one. All right. Which of the following, the next question is, which of the following is the yoke muscle of right lateral rectus? Yoke muscle of right lateral rectus. Tell me. Okay, Chandani says D. Anyone who differs with this? Okay, so uniformly, I get all the answers as D, D, D. Absolutely. So this was very easy, because when we talk of yoke muscles, so let's quickly see what is yoke muscle. Yoke muscle is the synergist in the contralateral eye, right? So when I am attempting this question, as I read right lateral rectus, I know it is talking of yoke muscle. So yoke is a contralateral synergist. So contralateral means other eye. Right ka other eye would be, the answer has to be in the left eye. So here in all the options, there's only one option which is talking of left, and that is option D. So this is how you quickly save on to time, right? So anyways, it has to be left, and there's only one option which is in left, and that is the answer. So when we talk of right lateral rectus, let's quickly see. If I have to move towards this side, my right lateral rectus moves into abduction, abduction, and my left eye moves into adduction. So which muscle is causing abduction? My right lateral rectus. And which muscle is causing adduction? My left medial rectus. Hence, the contralateral synergist is the yoke muscle. And what is the term synergist mean? Synergist mean the muscles, the group of muscles which are in the same eye. Which are in the same eye. And yoke means contralateral eye. And yoke means contralateral eye. Is that point clear? Yes, this is in view or in concern with the Hering's law of equal innovation. Perfect. Then we move on to the next one. Below given field indicates that the lesion is at. So before we attempt, tell me, what do you see in this field? What defect is shown in the field? So we just try to label it. This is nasal, this is temporal. So what do we get to see? Yes. So what field defect are we seeing here? This is a bitemporal bitemporal hemianopia. And where do you get to see? I'm so happy to that all of you are answering in sync with each other. All of you are answering correct till now, so that means we're really good on our preparations. Very good. All right, so this is a bitemporal hemianopia. So when we talk of bitemporal hemianopia, so what we are talking is of the nasal fibers, and the point where both the nasal fibers meet is the optic chiasm. Perfect, absolutely spot on, which is the involvement of optic chiasm, where the two nasal fibers decussate of the either side, they decussate and they come back to form the optic tract. So once the optic tract is involved, what kind of a field effect would you get? When we get the Yes, the lesions like pituitary adenoma, craniopharyngioma will have the involvement of optic chiasm, because we have the stalk and the pituitary right there. So anything which is arising from the pituitary gland will press onto this and craniopharyngioma. Right? So now you tell me, what are the lesions what is the defect that we get to see in the optic tract lesions? So what kind of a defect do you get to see in optic tract lesions? Quickly tell me. Optic tract lesions would lead to what kind of a defect? Perfect. It is, the word here is contralateral. Not to forget, it is contralateral homonymous hemianopia. Perfect. It is contralateral homonymous hemianopia. And what defect are you going to see with the optic disc? Optic disc would result in what? Do not never forget optic tract, and the lesions below it will affect the contralateral homonymous hemianopia. Optic disc would result in complete blindness of ipsilateral side. All right, is that clear? Yes, there's a total. Yes, right. And once the optic tract is involved, there's a contralateral homonymous hemianopia. Is the voice back? Now, can you hear me? Am I audible now? Am I audible now? Am I audible now? All right, great. All right. So now what we have is all right, so we were at optic tract and optic disc. So this question is done. All right. So now you have to match. You have to match A, B, C, D with image 1 and 2. So just tell me, what do you see in image 1, or what do you call the image 1 out of the 4 options given above? What is image 1? Is it occlusio pupilli? Is it Koipes nodules? Is it seclusio pupilli? Or is it Bisacca's nodules? What is it? Yes. So image 1, the answer here is B. The image 1 is the Koipes nodules. So how do you remember? P for pupillary margin, P for Koipes nodules. Right? P for pupillary margin, P for Koipes nodules. And what is seen here in image 2? Image 2 is what? What is image 2? Yes, image 2 is D. Right? So image 2 is D. Now quickly tell me, what is occlusio pupilli? What is occlusio pupilli and what is seclusio pupilli? So seclusio pupilli is 360-degree posterior signing के. Is what is seclusio pupilli. And what is occlusio pupilli? How did we remember? Occlusio pupilli is something which occludes the pupil. So this is an organized membrane. Organized exudates which form a membrane that occludes the pupil. Okay. So now no confusion. So you know what is occlusio pupilli. So occlusio pupilli, these are the organized exudates which form a membrane and block the pupil, is occlusio pupilli. Koipes nodules, the nodules which are present at the pupillary margin, and P for pupillary margin, P for Koipes nodules. S for stroma and S for seclusio pupilli. Sorry, S for stroma and S for Busacca's nodules. And seclusio pupilli is something which is 360-degree posterior signing. Right? So now no confusion in this. All right? Is it all? Is it okay? If yes, give me a thumbs up. I'll move on to the next one. Is everything okay till now? No issues? All right. So now you have to tell me xerophthalmia is caused due to deficiency of which of the following vitamin? Xerophthalmia is caused due to deficiency of which of the following vitamin? All right, it was very quick. It is absolutely right. The option is B, and that is the answer is vitamin A deficiency. So vitamin A deficiency results in xerophthalmia. Absolutely. Moving on to the next. A 70-year-old male whose cataract surgery is yet to be done came with fibrosis of the nucleus and says he can read the newspaper better than before. What is the probable diagnosis? Before you attempt this question, tell me, a 70-year-old male whose cataract surgery is yet to be done came with fibrosis of the nucleus. So which cataract is the question talking about? Which cataract are we talking about? You have to first tell me which cataract are we talking about, and then we'll come to the answer. Which cataract are we talking about? Is it nuclear cataract? Is it cortical cataract? Or is it posterior subcapsular cataract? The three kind of cataracts that we have in senile cataracts. It's not pseudo. So when it talks of fibrosis of the nucleus, please remember it is talking about brown discoloration of the nucleus. It's talking about brown discoloration of the nucleus, right? And then this both they are talking about nuclear. The process caused is nuclear sclerosis. The process is nuclear sclerosis. And once we're talking about nuclear sclerosis or the nuclear cataract, what it is called, it gives you a second sight. And that is because of, you are absolutely right, everyone, that is because of index myopia. So why we call as index myopia and not index hypermetropia? Because it clearly says he can read the newspaper better than before. So this means the vision which is better at near than distance. All right. So hence it is index myopia. Is that clear? So index myopia. This was simpler. All right. A 10-year-old child is diagnosed with amblyopia in one eye. A 10-year-old child is diagnosed with amblyopia in one eye. What will be the best treatment? Tell me, what will be the best treatment? The question talks about a 10-year-old child. So is it occlusion therapy, observation, refraction with near addition, or radial keratotomy? All right. So everybody says the answer is, it is very uniformly, the answer says occlusion therapy. Absolutely right. So that is the amblyopia treatment that we are given. And will we go for observation? No, the child is already 10 years. He is amblyopic in one eye. So observation is not to be done. Refraction with near addition. Well, if we would have just talked of a refraction first, then that would have been a better answer. But it says refraction with near addition. So no, the best treatment is that you give is you do a fresh refraction. That means you give them glasses with amblyopia treatment. With amblyopia treatment, which is the occlusion therapy. Right? So hence the answer is A. Radial keratotomy does not fit into the question. So the answer is very simple. Amblyopia, whenever the question talks about amblyopia, do not forget the occlusion therapy. All right. So even if the question is talking about the treatment below 3 years, that is why I have written this here. Always remember you have to start with refraction. So first you have to do a proper refraction. Just whenever it is talking of less than 3 years, you have to assess there is no squint. Which kind of amblyopia is the question talking about? If less than 3 years, he's talking about strabismic squint, he's talking about refractive amblyopia, or he's talking about visual deprivation amblyopia. So if the question is talking about strabismic amblyopia or refractive amblyopia. For both, the answer would be refraction. So I'll just write it down if you have a confusion here. So if the question talks about strabismic amblyopia or refractive amblyopia, what you have asked in less than 3 years, either case, the best answer would be you have to do the first step would be refraction. You give them glasses and you give them occlusion therapy, right? And then for strabismic, you go for surgery later. Whereas if we are talking of stimulus deprivation amblyopia, if we're talking about stimulus deprivation amblyopia, then the first option would be that the most common cause is cataract, and then we have to go for surgery. Is that clear? So then the best answer would be surgery. Okay, is that clear? Akash, is that all right? So that is the common take, that is the take from this question. All right, moving on to the next. Identify the image. Is it primary open angle glaucoma? Is it diabetic macular edema, optic nerve hypoplasia, or neuroretinitis? Or neuroretinitis. So what do you get to see in the image? You have to answer in the chat box. Meanwhile, I'll just let you know what are we. Okay, so what do we get to see here basically? What are we seeing in this image? What we're seeing is there is disc edema and there is a macular star. So what are you seeing in the image? What we get to see is there is disc edema plus this here is the macular star. So now tell me, what is the answer? So we have a lot of mixed responses between diabetic macular edema, between primary open angle glaucoma, between neuroretinitis, and optic nerve hypoplasia. So let's see one by one. So whenever I talk of primary open angle glaucoma, please focus, whenever we're talking about glaucoma, focus on the disc. Is there any cupping which is seen here? If you just enlarge the image, can you see any cupping? No, here is a small cup. So basically, what you get to see is there is elevated disc. There is disc edema with the margins are blurred. So this is not primary angle glaucoma. So this goes because there is no cupping. Okay. Then we come to diabetic macular edema. So now when you talk of a diabetic macular edema, it is very specifically saying diabetic macular edema. But then how will you answer about the disc findings? Because diabetic macular edema would only have the edema at the macula. Or if it is a diabetic neuropathy or it is a diabetic changes in the disc also, then it should have said diabetic disc with macular edema, then I would have taken it, right? So that is a diabetic neuropathy with macular edema or with CSME or with a macular star. But the question is just talking about diabetic macular edema. So there is no question of which is talking about the disc. So hence this also goes wrong. So then we come to optic nerve hypoplasia. So when we talk of optic nerve hypoplasia, how will you justify this finding? And optic nerve hypoplasia will have a smaller disc, which is not the picture like this. It will have no edema and it will have no splinter hemorrhage. Right? So this also goes out. So the answer which is left here is, the answer is neuroretinitis. The answer is neuroretinitis. retinitis. So what is neuroretinitis? Neuroretinitis is a variant of optic neuritis where you have papillitis, you have retrobulbar neuritis, and you have neuroretinitis. So what are those three things that we talk of? The three things in optic neuritis, the three variants that we talk of in optic neuritis is: one is retrobulbar neuritis, then you have papillitis, and you have neuroretinitis. Okay, so what is the difference between macular star and macular hole? See, it's very different. When you talk of macular hole, number one, there will not be the exudates which are deposited in a star-shaped manner like this. So when you have that exudates which are deposited in a star-shaped manner, that has to be a macular star. And why would a hole have these exudates in the Henle's layer? Right? So that is a macular star when you have exudates in the form of a star which are deposited in the Henle's layer. So when you talk of a macular hole will be a small lesion which is small, punched out defect in the retina. So that would simply be like this, that you have when you see the fundus, so there is a disc which is like this, which has the, like the vessels, and what you get to see is a small clear cut appearance like this, right? So that it has clear cut margins with no exudation along. The disc would be completely all right, no signs of inflammation, complete small breach which is present in the layers of the retina. So that is what you get to see is a macular. And macular star, when we talk, so macular star will again there will be deposits in the Henle's layer like a star. Is that clear now? Okay, Kash. So this the answer here is neuroretinitis. All right. So then we move on to this one. 40-year-old male developed ptosis, which worsened as the day passed, and it improved on edrophonium administration. What is the probable diagnosis? So the question is talking about a variable ptosis. The question is talking about a variable ptosis which is worsening as the day progresses and is improved on the administration of a drug which is edrophonium. So the disease talks, we all know there is a tensilon test, there's an edrophonium administration test, there is a ice pack test, there is a sleep test, anti-musk antibodies we detect. So whenever the question talks about any of these, absolutely right, the answer in all these situations would be myasthenia gravis. So myasthenia gravis, when you have a variable ptosis which worsens as the day progresses, that means once the patient is tired, after the entire day, the ptosis is going to progress. Right? So all the tests that I told you, tensilon test, neostigmine test, edrophonium test, ICE test, sleep test, anti-mask antibodies, all these come and when we talk of myasthenia gravis. All right. So below image with a characteristic finding can be seen in. So first, before you answer this question, you have to tell me what is the characteristic finding that is seen in this image. Don't give me the answers. First, you have to tell me what is the characteristic finding that is seen in this image. Yes, absolutely. So what do we get to see here? What we are seeing is the cherry red spot. What do we get to see in this image? What we are seeing is the cherry red spot. So which disease do you get to see the cherry red spot? The answer is absolutely right. All of you have rightly said it is CRO. What is the appearance of CRO known as? What is the appearance of CRO known as? Tell me. The appearance of CRVO is called as. So what is the appearance of, this is the cherry red spot. So what is the appearance of CRVO called as? Absolutely. It is called as splashed tomato appearance. And what do you call it? What do you call the appearance of a CME? What is the appearance of CME known as? Tell me. What is the appearance of a CME known as? It is famously called as what? CME? Cystoid macular edema gives you the appearance of a flower. Now anybody wants to attempt? Flower. What kind of an appearance? Anyone? Flower. Okay, I'll write. Flower petaloid appearance. Okay, so now we all know. So in CRA, what do we get? We get a cherry red spot. In CRVO appearance is called as a splashed tomato appearance. Cystoid macular edema, we get a flower petaloid appearance, which is seen on fundus fluorescein angiography. Okay, so that is the petaloid appearance. All right, so now you have to identify this lens. What is the answer? Which lens is this? First, before you attempt the answer, tell me which lens is this? Tell me, which lens is this? All right, so this is the lens which is used for gonioscopy. Now tell me, which lens is this? You say it's a gonio lens? Well, I would say gonio lens is the one which is used for direct gonioscopy. So now tell me, can anyone name this lens? So it is wrong. It is not gonio lens. Okay, so I will write it down. The lens that we see here is the Goldman single mirror lens. All right. So basically what you see here is a single mirror. Hence, this is called as a single mirror lens. So one answer here is single mirror lens. So this is a Goldman single mirror lens. Then you say gonio lens. Gonio lens is the term which is used for the lenses which is employed for direct gonioscopy. What is gonium prism? Gonium prism is the term which we used for lenses for indirect gonioscopy. So this is also the correct option. So it is a gonio prism. So gonio prisms are the ones which are the lenses which are used for indirect gonioscopy. It is not a 3-mirror lens. It is not a 4-mirror lens because we can see one lens here. So this is a Goldman single mirror lens, or it is called as a Goldman single mirror gonio prism. These are used for gonioscopy. If anyone wants to read more on gonioscopy, again I'm telling you, gonioscopy, there's a free special class which is already recorded on the Unacademy app. There is a free special class on gonioscopy, right? On gonioscopy. So you can go and listen to that class. That's just a 1 hour class. It has all the details of the principles of the lenses used in gonioscopy, direct, indirect gonioscopy. Everything has been discussed there in detail. Okay, so which now you should not forget, this is a single mirror lens. You can see one mirror, and that is the Goldman single mirror lens or gonio prism. Now you have to tell me what is the angulation of this mirror in Goldman single mirror lens. What is the angulation? What is the angulation? That means what is the angle at which this lens, this prism is placed? Tell me. Anybody who wants to attempt this? What is the angulation? It is 62 degrees. Now do not forget. So single mirror, Goldman single mirror lens. This one single mirror lens, one prism is placed at an angle of 62 degrees. Is that clear? Sorry, travel with Chandan, it is not 45, it is 62 degrees. But now you know and you're not going to forget. All right, so we move on to the next one. Now you have to tell me which instrument is this and what is the principle it is based on. Tell me the name, you name this instrument. So this is an instrument which is mounted on the slit lamp. This instrument is mounted on the slit lamp. So which instrument is this? It is not tone open. It is again linked up with the same person whom we have just named in the previous question. It is not air puff. So see carefully. There is a prism attached here with this instrument is mounted on the slit lamp. So this is a Goldman applanation tonometer. This is a Goldman applanation tonometer. And what is the principle it is based on? It is based on the Imbert-Fick principle. Okay, and you get to see the Myers like this. One is like this and one is like this. So basically you need to align these Myers when you're calculating the intraocular pressure. So you might get this image also in the question. So whenever there's this image which is there in the question, please remember the question is talking about the Goldman applanation tonometer, right? Which is also called as G80, the Goldman applanation tonometer, which is based on the Imbert-Fick principle. So now you tell me which instrument is this and what is its principle? Any guesses? So this is basically, it's a handheld instrument, right? The one which we saw in this one, it was slit lamp mounted. And this one, this instrument is a handheld instrument. Now, anybody who wants to attempt? All right. So this is a Perkins tonometer, right? And again, the principle is the same as applanation tonometer. It is based on Imbert-Fick principle. Right? So there is a handle and this rests on the forehead of the patient. And then again, there is a prism, just like we saw, see here, just as the similar one that we saw in the applanation, there's a prism which measures the intraocular pressure. So please see the image carefully. This is a Perkins tonometer, which is based on the same as the applanation tonometer, the Imbert-Fick principle. So now we know two instruments which are based on Imbert-Fick principle. That is the slit lamp, which is the one which is mounted on the slit lamp is the Goldman applanation tonometer, and the handheld instrument is called as the Perkins tonometer. Is that clear? Now tell me, which instrument is this? So Imbert-Fick principle is basically based on that you calculate the pressure inside this sphere-like structure by applanating a surface which is around 3.06 millimeters. So by the amount of pressure which is required to indent this surface, we calculate the pressure inside that. So that's a little more in advance. So that is an Imbert-Fick principle. Now you tell me, is that clear? So that is the Imbert-Fick principle, right? Okay, so yes, absolutely right, Akash. This is a tono pen. Absolutely right. This is a tono pen. This is a tono pen, and it is again which is used to measure the intraocular pressure, which is a Meckey-Marg type of tonometer. Okay. I did this image. What do we get to see? It's not a dendritic ulcer. So if you see carefully, it's not, the image is not of cornea. First, see where is the image. The image is actually of retina, right? You can see the optic disc here, and then there are these pigment spicules here. Absolutely right, Mohammed Shafi Abdullah. Very good. So basically, what we are talking about is retinitis pigmentosa. How do you get to see? If you see carefully, this is the classical bony spicules that we get to see. These are the bony spicules which are seen in this image. See the pigments here? So this is retinitis pigmentosa. So what are we dealing with? We are dealing with retinitis pigmentosa. So here, I would like to just take a minute and say, yes, the patient will present to you with a history of night blindness. Whenever you have doubt, whenever you are not unsure of what the image is, just see, when you have cornea would be black. There would be no vessels like this. So if you see carefully, there is a disc whenever we're talking about the retinal images. So retinal images will almost always have a disc. Okay. So that's how you kind of, you can solve your confusions. So now you have to tell me, what are the classical fundus findings in such patients? I could already see there are certain answers which have come, which say waxy disc pallor, which say attenuated arterioles, and there's a third factor also. So whenever we talk of the characteristic fundus finding in these patients, there are three factors. There are three things that you should remember. So this is retinitis pigmentosa. This is retinitis pigmentosa. Again, a similar picture. And now you have to tell me, what are the three factors which are linked to the fundus findings in retinitis pigmentosa. When you talk of its inheritance pattern, let me tell you, retinitis pigmentosa is one condition which can be inherited in any pattern. It can be sporadic, it can be X-linked, it can be autosomal dominant, it can be autosomal recessive. It can be inherited in any pattern. So when you see this, please remember what are the three important fundus findings. Number one, which you all have mentioned, there is a disc pallor. There's a waxy disc pallor. Number two, there is arteriolar attenuation. And number three is bony spicule-like pigmentation. Right? So let's quickly see. Let's quickly write it down so that there is no confusion. So one is optic nerve head, or what you call is optic disc pallor. So you have a pale optic disc. Number two is, I have written here, there is arteriolar attenuation. And third thing is bony spicule-like pigmentation. All right. So now there should be no confusion. And the patient will classically give you a history of night blindness and a history of positive family history. Right? So whenever a question has a fundus picture like this, where you get optic disc pallor, where you have arteriolar attenuation, where there are bony spicule-like changes, along with the question talking about a history of night blindness, or there is difficulty of vision or a poor vision when the sun sets down, or in the evening or in the night, and there is a positive family history, or there's another one who's having similar symptoms in the family, please note the question is talking about retinitis pigmentosa. So these are the different ways the question can be asked. All right. Okay. All right. So then we move on to the next one. A child has difficulty in watching the blackboard. The likely diagnosis is, this is easy, but you have to quickly come down to the answer. So a child has difficulty in watching the blackboard. The answer is, tell me. So whenever we talk of retinitis pigmentosa, we still do not have a proper cure for the treatment. So we eventually land up with giving them, vitamins, multivitamins, giving them stem cell therapy is something which is undergoing research. So stem cell therapy is there. Omega-6 fatty acids can be there. No consanguinity, no marriages within the family, genetic counseling. These 5 things are important when we talk of retinitis pigmentosa, but we still do not have a cure for the disease till date. And the ones who have poor vision, we can go for a bionic eye or the macular or the retinal prosthesis. Right? All right. Absolutely right. The answer here is myopia. And what is the other name of myopia? What sightedness do we call it? Is it nearsightedness or is it farsightedness? Myopia, I know this was very easy, but what I want to tell you, what is the other name of myopia? Is it nearsightedness or is it farsightedness? See, remember, when we talk of myopia, we are able to see near, but not distance. This is myopia, hence it is also called as nearsightedness, because we are able to see the near, but we cannot visualize the distance. So this is the nearsightedness. Now you have to tell me, what do you see in the image? Which refractive error is this? Is there a refractive error or there is a no refractive error? So if you want the options, I can give you the options also. The options would be, is it myopia? Is it hypermetropia? Is it emetropia? Or is it astigmatism? Quickly tell me now. Absolutely, absolutely right. Very good. The answer is, this is emetropia. Why this is emetropia? So just see carefully, the parallel rays from infinity come and focus on the retina. So this is exactly what we want in a relaxed state of accommodation. When the parallel rays of light coming from infinity focus on the retina is what is called as emetropia. So if with the similar options we go to this image, what is it? The options that you have now with this image, you have to tell me what is the answer. Is it myopia? Is it hypermetropia? Is it emetropia? Or is it astigmatism? So what is this image signifying? This image on the screen signifies which refractive error? Tell me, which refractive error are we dealing with? Absolutely right. So what we are dealing with here is, because the rays are focusing in front of the retina, so we are dealing with myopia. Perfect. And which refractive error is this? So now where are we? We are behind the retina. When we are behind the retina, which refractive error are we dealing with? So this image is depicting which refractive error? So by B, you want to say, oh, okay, perfect. So what we are dealing with is we are dealing with hypermetropia. Very good. We are dealing with hypermetropia. Perfect. Then we come to biconcave lens is used in the treatment of. So when I say biconcave lens, now you have to tell me, I will draw two images. So if I label this as 1 and this as 2, so now you have to tell me first, the question is which out of these two, 1 or 2, is a biconcave lens? Which is a biconcave lens? Is it 1 or is it 2? All right, so I have mixed responses into this question. First, you have to tell me the question is talking about a biconcave lens. So, which out of these two is the biconcave lens? Is it 1 or is it 2? First, you have to answer me. So, yes, absolutely right. 1 is the biconcave lens. And this 2 is the biconvex lens. So biconcave lens is also, is it a converging lens or is it a diverging lens? You're right. One is a concave lens. So biconcave lens, remember, is it a converging lens or is it a diverging lens? So biconvex lens is a converging lens. Biconcave lens is a diverging lens. So now you tell me, biconcave lens, the question is talking about this lens. The question is talking about biconcave or the diverging lens. So which disease out of these do we use? So biconcave is a diverging lens, and which disease do we use it? So we use it in myopia. All right. So when we talk of biconvex lens, which is a converging lens, is used in hypermetropia. Right. So biconvex lens is used in hypermetropia as well as presbyopia. Okay. So astigmatism, when we talk of astigmatism, we use toric lenses. We use toric lenses, or is also called as spherocylindrical lenses. Okay, also called as spherocylindrical lenses. All right, so then we can move on to the next one. Visual acuity of a patient improves on looking through the instrument in the picture. This indicates what? So before we get to the answer, you have to tell me what is this instrument? What is shown here in the picture? Which instrument is shown here in the picture? Yes, absolutely. So we are dealing with it is the complete name is, it is a pinhole occluder. The complete name is a pinhole occluder. So when we use the word pinhole occluder, the answer is very simple. It is used in refractive errors. So when we use it in refractive errors, the best corrected visual acuity on using a pinhole will improve. The best corrected visual acuity on using a pinhole in refractive errors will improve. Whereas in macular diseases, the best corrected visual acuity will decrease. will decrease when we use a pinhole occluder. So any opacity which is present, or any issue if it is present in the central visual axis, that means the central part of the cornea, the central part of the lens, or the fovea, or the macula, the with the use of the pinhole, the vision would reduce, the vision would decrease. Whereas when we're talking of the refractive errors, the vision with the visual axis being absolutely clear, the vision would improve. All right, so next we move on to this. So blowout fracture is seen in which of the following? So here what we're talking about is, we're talking about a blowout fracture. So blowout fracture is seen in tennis ball injury, chisel and hammer, sudden fall, or punch at the chin from below. Tell me what is the answer. So where, in which scenarios and the ones in the option will you see the blowout fracture? All right. So I think we have Shri Devi who says A, and rest all others say D. So that means we know it is not chisel and hammer, and we know it is not sudden fall. So the confusion here is between A and D. Let me tell you, when we talk of a blowout fracture, there has to be an impact directly at the eye, which is larger than the orbital rim, right? So tennis ball injury, absolutely right. So tennis ball injury is absolutely right. And what about option D? It says punch at the chin from below like this. No, had this said punch at the cheek, would have been the correct option. Since it says punch at the chin, punch at the chin is the wrong answer. So had this, the correct answer is at the cheek. Punch at the cheek would be the correct answer, not at the chin from below. If we talk of a punch here, nothing is going to affect the orbit, right? So now is it clear? It is not punch at the chin. The answer is punch at the cheek. So now you know what is the correct answer. The answer is tennis ball injury. And when we talk of the blowout fractures, we talk of the fracture of the blowout fracture is fracture of the floor of the orbit, right? And then it says identify the sign marked with red arrow in a child with history of trauma. So it's basically the continuation of the above question. And what do you get to see? Okay, move on to a side which says where you can see the red arrow. I'll enlarge the image so that you can see clearly. I will enlarge it more and you can see. So which sign is this? Tell me. Which sign is this? Absolutely right. So what we're seeing here is in the red arrow marked here, this sign is called as the teardrop sign. So where is the fracture? The fracture is here in the floor of the orbit, right? So which sign is this? This is called as the teardrop sign. And where do you get to see is this sign is seen in the fracture of the floor of the orbit. Floor of the orbit. Right? So this is the teardrop sign. All right. So then we move on to the next one. A child presents with low vision in one eye. The child presents with low vision in one eye with no other abnormality and normal fundus examination. So what is the likely diagnosis? Myopia, hypermetropia, amblyopia, or astigmatism. So it is very, very simple. It is very clear. It says low vision in one eye with no other abnormality. When we talk of no other abnormality, that means there is no organic cause. And when we say no organic cause, what is the treatment? What is the diagnosis? Absolutely. The answer is D. This is simple. So amblyopia, unilateral or a bilateral. Please remember, unilateral or bilateral reduction in the best corrected visual acuity when there is no organic cause. So how do we know there is no organic cause? Because the question says there is no other abnormality and there is a normal fundus examination. So the answer is amblyopia. Now identify what do you see on the screen. What do you get to see on the screen? What is there this on the screen seen? So what is this that you are seeing on the screen? Absolutely. So it is, we complete. What is this? This is an intraocular lens, all right. What kind of an intraocular lens? Now see the optic. Where is the optic and where is the haptic? So when we see here, the central part that we get to see is the optic, and this here is the haptic. So we see the optic is absolutely plain. There is nothing which is drawn on the optic. So what is it? It is a monoocular single piece. Why single piece? Because if you see carefully, the optic and the haptic are absolutely similar. So they are monoocular single piece posterior chamber intraocular lens. Is that clear? So it is an monoocular single piece posterior chamber intraocular lens. So, right, so this part is called the optic, and these here is called as the haptic, right? So it is a monoocular, means single foci, single piece, posterior chamber IOL. Vis-a-vis, if you see this carefully, so what do we get to see here is, we get to see multiple rings here, multiple rings in the optic. So now what is this? What is this now? So when you see multiple rings in the optic, now here what we get to see? We get to see multiple rings. We get to see multiple rings in the optic. So when we get to see multiple rings in the optic, what is it? It is again, it is a multifocal single piece. It is single piece. Why? Because again, the same material, the optic as well as the haptic. So it is multifocal single piece posterior chamber intraocular lens. We call it, why do we call it multifocal? We call it as multifocal because it has multiple rings. And which are the two patterns of multifocal IOLs? The two patterns of multifocal IOLs is, it can be diffractive or it can be refractive, right? So this is the intraocular lens. Vis-a-vis, when we come to this kind of a lens, now which kind, what is this lens called as? So here what do you get to see? We get to see hinges. Hinges are present here in the haptic. So which kind of a lens is this? Tell me, which kind of a lens is this? This is called as a accommodative lens. Accommodative intraocular lens. So basically what happens is, these, with the help of these hinges, the lens tries to move in front. It moves anteriorly when you try to do the accommodation. So when you get the something like this, when you get the hinged haptics, please note the question is talking about accommodative IOL. All right. So then we come to the differences in the refractive error of two eyes is causing decreased vision in one of the eyes. What is it called? So when we're talking about the difference in the refractive error of two eyes causing decreased vision, so what is it? Is it amblyopia? Is it anisometropic amblyopia? Is it refractive error or anisoconia? Tell me, what is the answer? So I had kept this question here just to clarify this thing. It is a very simple question. So the if you ask me the answer can be A as well as B. So both are talking of amblyopia. So what would be the correct answer? The correct answer would be anisometropic amblyopia. But please remember, whenever we talk of attempting questions in exams, it is always the best option out of the four. I mean, whatever options you have, the best option has to be answered. If there was something else in place of B, then I would have answered amblyopia. But option B is more specific in an amblyopia, which is because of the difference in the refractive errors, which is exactly what is the question talking about. Hence, the answer is anisometropic amblyopia and not just amblyopia. Is that clear? And not just refractive error and not just amblyopia. Aniseconia, obviously not. So what is aniseconia? Aniseconia is when there is difference in the images of the two eyes. Is that point absolutely clear to in your mind? So there will be some googly questions. There will be certain questions which would have the options like quite similar as is here in A and B. So whenever you get in a fix like this, always be more specific. The more specific answer is the correct option. Is that clear? Is that okay? All right. So then we move on to the next one. A worker incurs trauma while working with chisel and hammer. So there is a trauma while working with chisel and hammer and presents to you in the OPD. You notice a penetrating injury and the next best investigation would be. Again, it's a similar question what I wanted to teach you in the previous question and this question. So you all say CT scan. Why not answer C? Tell me. So when we attempt this question, MRI absolutely goes out of the question because what we are dealing with is a metallic injury, chisel and hammer, right? So now we are left with two questions, CT and B scan. Obviously, nuclear radiology is out of the option. So when we talk of a B scan is also something which can detect foreign bodies. This B scan is something which is operator dependent. Okay, so when you have these two options, so B scan is the right option, but out of B scan and CT scan, which is the better option? The better option is CT scan. Hence, it is the answer. If CT scan would not have been in the option list and only B scan was there, then I would call it as an option which is correct. But since CT is better than B scan, right? So whenever we are attempting, just remember we have to answer the best one, the best option, which is a more specific option. Hence, these two questions were kept here to clarify onto this point, right? So B scan is also correct, but CT scan is better in such investigations than B scan. Hence, CT scan is the answer. Is that point clear? Can I have a thumbs up if it is clear? Then we can move ahead. Can I have a thumbs up if this point is clear? That what answer, which option is to be said if you have two or three options which you find is correct as to what question has been asked. Great. All right. So now you have to identify this instrument. Which instrument is this? Tell me, which instrument is this? Tell me, which instrument is this? So as always, I try to keep lesser of the options because once you learn this way, always attempting answers in the exam becomes easy. Absolutely right. So this is the Calazion clamp. This is the Calazion clamp. So here, this is the rim and this is a flat surface. So now you have to tell me, where do you keep the rim? Which surface do you keep the rim? The rim is placed where you are going to give the incision. So at the incision side is where you place the rim, whether on the conjunctival or on the skin side, right? So basic purpose here is to fix the chalazion and also it gives you a type of hemostasis. So that is the use of a chalazion clamp. All right. Now this instrument shown below is seen in the operation theater on the trolley which is laid down for following surgery. So before you answer this question, tell me which instrument is this? Identify this instrument. Which instrument is this? Absolutely. You can expect these questions in the exams. That is why we are discussing here. That is why there's entire story of doing, reinforcing your short-term memory that I exactly said in the beginning of the session. Okay, so this is actually, which instrument is this? I said which instrument? This is a kerosene bone punch. So this is a kerosene bone punch. And which surgery do you get? Absolutely right. What you all have written, it is seen in DCR. It is used in DCR. Hence, it will be seen on the trolley of the DCR surgery, and it is used to enlarge the osteotomy. So, what is the function of kerosene bone punch? Kerosene bone punch is used to enlarge the osteotomy. Okay. All right. So then we moved on to this. Now you identify this instrument. Which instrument is this? Nayana, so now you are clear. It is not B, it is not evisceration, but it is DCR. All right. So now identify this instrument. All right. So the hint here is it comes in various sizes. It is available in various sizes from 0 to 8. Now, anybody? So the answer is this is the Bowman's lacrimal lobes. So again, if you have any doubts on the instruments, I again have the free special class which I have recorded on ophthalmic equipment. On ophthalmic equipment series 1. There I have almost discussed most of the ophthalmic instruments, and the second part of that class is due on this in this month. So that will also be dealing with the OT instruments. So you can go through that class which is there on the Unacademy app, and it's a free class. It's a free session which is there. It is already recorded. You can go and visit that. So this is basically a Bowman's lacrimal probe which is used to identify the sac doing a DCR surgery, and which is also used to during the syringing and probing. All right. Okay. So now you identified this instrument. So the hint here is there is a central cleavage, which is also called as the optic nerve guide. How many PYQs we can expect in the exam? See, my answer would always, when we talk of ophthalmology, expect something to be coming between, say, 3 to 6 to 7, between 3 to 7, any number. I expect them to be repeated because it is any time. And if you ask me, the last NEET PG and this, there will be an overlap of 1 to 2 questions. So you take on an average, if you build on those 3 to 7 and then 2 to 3 of NEET PG, so you are up by 10 MCQs. And as I have already taken the plus course of advanced ophthalmology on Unacademy, so that is also something which is above the baseline. That's an advanced plus course which was taken, which covered lasers. So that's again a very important topic which I'm anticipating this time. So if anyone who wants to learn more about lasers can visit that class, which is Advanced Ophthalmology Session 1. So those are just 2 sessions of 1.5 hours each. You can learn from there also. All right. So, okay. coming back to this. So what is this instrument? This is basically the enucleation. This is the enucleation spoon. Enucleation spoon. Why do we call it as enucleation spoon? Because you have to identify this cleavage here, right? Which is for the optic nerve guide. Absolutely. Okay. So come up with a comprehensive course for FMG. Even if you want it in a live class, we will have it sooner on the app. But if you want to see the recorded, it is already recorded. I have already recorded a comprehensive course on FMG, which is there on the Unacademy app. You can visit that and you can enroll for that, or you can use my code for the any added advantages. Anyways, coming back to where we were. So this was the enucleation spoon. And now if we come to this, so which instrument is this? You see here a blunt-ended rectangular instrument. So which instrument is this now? This is the evisceration spoon. This is the evisceration spoon. And how will you differentiate from enucleation? There is no central cleavage or there is no optic nerve guide, because when we are doing an enucleation, we want a part of the optic nerve, but here we do not need any part of the optic nerve. There is a rectangular blunt edged spatula like end which is present, which scoops out all the uvea, leaving behind the scleral frill. Right? So this is an evisceration spoon. All right. So with this, I will stop the today's class. We will continue with doing more MCQs. We'll continue with doing more of this later. Right? So that is another class, which is again 1.5 hour session, which is planned for Monday. That's again the same pattern. We'll be revising more of PYQs, more of anticipated questions, discussing more of questions, learning more about it. Right? So that is it. Yashwant Rao, thank you so much. Well, this was my attempt to build in your short-term memory. Again, as I said, we have been discussing on length about all these topics throughout the year. So now is the time when I'm just trying to brush up the things quickly and build in a short-term memory for you for your exam. So this short-term memory, this image, this visual memory is going to help you, right? So with that, I will sign off. And as I always say, this is the time of revision. Keep revising more, but do not compromise on your sleep. If you have a good sleep, you will be fresh, and a fresh mind is what you require to come out with all that you know, right? So revise, 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 and have a good sleep and good food. You have the world and you have the entire time with you after a few days, right? So till then, I'll sign off now. Take a good break, take a good sleep. Good night.